Today's topic is newer parameters in cell-based counter. And our speaker is Dr. Sukesh C Nair, Professor in Department of Transfusion Medicine and Immunohematology, CMC Vellore. And chairperson is Dr. Anil Handhu sir, and Director Lab Medicine, BLK Max Super Specialty Hospital, New Delhi. Today's moderators are Dr. Aarti, myself, Assistant Professor in National Institute of Medical Sciences and Research, Jaipur, and the Dr. Tirupura Sundari, Professor in Vinayaka Mission Medical College, Karikal. Our webinar hosts are Dr. Anita Borges, ma'am, Consultant Pathologist, Center for Oncopathology, Tata Trust, Mumbai. Dr. Sumit Gujral, sir, Professor in Department of Pathology, Tata Memorial Hospital, Mumbai. There are few reminders and few disclaimers. Few more. So our upcoming talks are slide seminars on how to morphologically approach poorly differentiated malignant tumors by Anita Borges, ma'am, Consultant Surgical Pathology, Center for Oncopathology, Mumbai, on the 28th March, 7 p.m. And the next talk is 2nd April on spectrum of fatty liver disease by Dr. Rajni Yadav, madam, Professor in AIIMS, New Delhi. Let's start. So, sir, Sukesh Nair, sir,
Yeah.
you can start your video.
Okay, fine.
Share screen. You can share your screen.
For sure. Okay. Okay. Are we ready to go?
Yes, you
Yes,
can.
Okay, fine. Okay. So, first of all, my heartfelt thanks to Dr. Sumit and Dr. Anita for inviting me to give this talk on cell counters, one of my favorite topics. And very fortunate to have Dr. Anil, who is going to chair this session. And, you know, there's no other better person in this world who can chair this session. When you look at a cell counter, whether you look at it when it's processing sample or when you take a printout, this is what you get. You'll have the numbers, but you also have some pictures. And that's what a cell counter does. You know, it creates, because it actually wants to quantify whatever it is measuring, you know, in some way or the other, and then it gives you the output in histograms. You know, the white cell histogram, the platelet histogram, the red cell histograms. But most of the people ignore it. They only look at the values, and you know, values are quite good because, you know, they're derived from these histograms. So there's nothing untoward about these values. Now, some of the cell counters will give you what is known as differential count of the white cells. So you have the differentiation of white cells into lymphocytes, monocytes, neutrophils, eosinophils, basophils, with various mechanisms. So, you know, I have got the top 6 manufacturers in the world who have their cell counter data here. You have the Beckman Coulter, the Sysmex, the Advia. These are probably some of the oldest ones. Then you have the ABX, also one of the oldest. Mindray, some fairly senior. I mean, recent, but of course it's basically a reproduction of the Sysmex. And then you have a new cell counter, though from an old manufacturer called Abbott, called Alinity. So these are the topmost manufacturers in the world, and you can see their display of the 5-part cell counters. Now, why do cell counters do better than any process of counting cells or identifying cells? because you must realize that it samples and analyzes cells which are 80 to 100 times than any morphological checking process, whether it's a manual count or there's a smear count. It is going to analyze 80 to 100 times more than what we can do manually. And at the end of it, it arranges a proper disciplined output. Now, the issue is, can the cell counter output be more specific to a disease or a disease process? A lot of newer parameters are being developed. Some are already developed. Some are being derived based on revisiting existing data. And this has probably allowed early diagnosis, and very, very early, as it is, the cell count is a screening test, so that it can indicate the outcome as well as direct the prognostic process of a disease. And in some ways, I have found it very, every time I found it as a life-saving tool early in the disease process. Now, 5 major platforms that do 5-part differential. How do they differentiate the cells from each other? So obviously, when a cell counter is subjected to a blood, it processes the blood. Like, when you do a manual red cell count, you have Hyams fluid. When you have a white cell count, you've got a Turk's fluid, which lyses the red cell, and only the white cell nucleus can be seen. When you do a platelet count, you have the formol citrate saline, which makes the platelet refractile. So all these processes, these are processes which allows the cell to be differentiated easily. So obviously, when a white cell is going to be differentiated into 5 different types, we don't want anything else to interfere with it. So the most important thing is that to get rid of the red cells, because red cells are in millions. So now, when they get rid of the red cells, does it have an impact on white cell is something that we need to understand, because that determines the outcome of the differential count. So are the processes that are destroying the red cells creating the white cells into a near native state? Or are the white cells losing cytoplasm to allow dyes? Because, to allow dyes to go in, like fluorescent dyes, staining dyes, they have to make holes in the cytoplasm, which basically means the cells are going to shrink. So, and you must realize this, all this analysis is going to happen within 25 seconds. And this short time of these changes, will it impact the outcome of the differentiation? Now, obviously, the next after the lysis is basically what all signals are generated by the cells and how the cell counter is going to look at the signals that come out, basically through the photomultiplier tubes. Now, based on that, it analyzes to discriminate based on the physical attribute, size. Now, obviously, when we talk about, making punctures, the cells are shrinking, so size cannot be good in certain cell counters, but in certain cell counters, size is good because the cells are in the near native stage, like the DXH from Beckman Coulter, Alinity from Abbott, Umisen from Horiba, and sometimes in somewhat Advia also can determine size. Fluorescence, the only cell counter which use fluorescence are basically the Sysmex and the Mindray. But in addition, Alinity also uses fluorescence to differentiate between cells. Basically, the fluorescence is, it's a nuclear dye. It dyes, it stains the RNA or the DNA differentially, and based on that, it will differentiate between the cells. Staining and light loss. Like, for example, Advia will stain with oxidase, and based on that, it will either absorb light or reflect light, or refract light, so that there will be a possibility of a loss of light because of staining as well as some other process. That's done by Advia and Umisen, which is from Horiba. Then the nucleocytoplasmic content, the only cell counter which does that is DXH, because DXH is the only cell counter which has got which analyzes cells based on 3-dimensional analysis. Most of the others are multiple 2-dimensional analysis. So it does analysis on 3 axes. But interestingly, all the cell counters do not ignore granularity. So here, if you look at DXH, here you can look at DXH, it's a population, large population of cells. Now here you have granularity or scatter along the y-axis, x-axis, and size along the y-axis. Now cells which are not very large along the y-axis, but also don't have much scatter are the lymphocytes. Cells which are similar in number as lymphocytes but have more granularity than the lymphocytes and larger than the lymphocytes are the neutrophils. Look at the cells which are same size as neutrophils along the y-axis. They are the same size, but they have more scatter or more granularity than the neutrophils or the eosinophils. The cells which are the largest along the volume, but they don't have much scatter, are the monocytes. Now, obviously, the basophils are hidden behind the lymphocytes, and they use the third axis, that is the nucleocytoplasmic ratio, to differentiate between lymphocytes and basophils. Now, here you have fluorescent-based cell counts. You can see that along the x-axis again is scatter, along the y-axis is fluorescence. So you can realize that, the nucleus of the neutrophil has got mostly heterochromatin. There's hardly any euchromatin. So the nuclear staining dye will not stain the neutrophil nucleus as much as it may stain other cells. So you can see that here, you can see the neutrophils along the staining wise, y-axis is hardly much of staining. The eosinophils, which have got more scatter, they have more heterochromatin than the neutrophils. So therefore, their staining will be lesser. So that means along the y-axis, the eosinophils will have lower staining than the neutrophils. Then you have the lymphocytes. So you have the small lymphocytes and the large lymphocytes. The small lymphocytes have more heterochromatin. The large lymphocytes have more euchromatin. So you can see that from the small lymphocyte, which is almost similar staining as neutrophils, you have more staining with the large lymphocytes. And then you come to the monocytes, which are having a network like chromatin and takes up a lot of RNA dye. And therefore, you can see along the y-axis, the new monocytes are quite well stained compared. But of course, if you look at scatter, both lymphocytes and monocytes hardly have any scatter. Now, to differentiate between basophils, to identify basophils, they have an individual parameter, which is based on the fact that basophil contains the most acidic substance in our body. So in case if you're going to write another entrance exam, there'll be one trivia, which is the most acidic substance in our body. It's not HCl, it is heparin. Heparin has a pH of 1 because heparin is almost like sulfuric acid. And basophils contains heparin. So when you subject the white cells or the cells to a low pH, almost a pH of 2, all the cells will die. Not die, they degenerate. The only cell that will survive is the basophil. So based on the basophil chamber, you can see the basophils will be identified in a place along the size, because basophils will retain their size. All the other cells will lose their size. You can see that there. Now you talk about eumycin and Advia. Here you can see that along the x-axis is size, and along the y-axis is light loss. You can see that there's hardly any light loss for lymphocytes and monocytes, and you can see the monocytes are large in size. The neutrophils, you can see that there, the green population, they will have more light loss compared to the monocytes because they have more scatter, and they of course will be also staining up with the dye which stains the peroxidase granule. And then you have the eosinophils, which have got the largest light loss, but along the size, it is the same size as neutrophils, but smaller than the monocytes. Now, if you look at the Advia is a precipitant dye. It's a peroxidase dye, and you can see that neutrophils will be staining largely with the peroxidase. The eosinophils also stain with peroxidase. So along the peroxidase staining, which is along the y-axis, you can see that the eosinophils will be almost at the end here, but the light loss that happens along the y-axis is not as much in the eosinophils, because it's a precipitant dye. The light may not pass through the eosinophils for creating light loss. So that was the philosophy. And the importance about Advia is that it does not analyze red cells and platelets based on impedance, but it based on light scatter data. And that's alinity here. You can see that there is, the lymphocytes here. The blue population is lymphocyte. The purple population is monocyte. And you can see the scatter. IAS is scatter. That is mostly in the neutrophils and the eosinophils. But based on the polarized light scatter, you can see the eosinophils can be differentiated between neutrophils. And you can see that, based on the size, the monocytes are larger, lymphocytes are smaller, and scatter-wise, neutrophil. So based on these particular philosophy of size and scatter and other philosophy, it differentiates the cells from each other. Best part of the cell counter is that if suppose the cell falls into an area which is not defined by the flagging parameters of the cell counter or the algorithm of the cell counter gets a little confused. Then the cell counter says, okay, no, I have been developed for, identifying cells, and I know where the cells are falling. So the cells counters will start suspecting abnormal cells, and they give what is known as suspect flagging. It can identify a metamyelocyte, a myelocyte. It can even identify whether the blast is a myeloblast or a monoblast or a lymphoblast. So based on that, it will give you suspect flagging, which is called as blast flags. And therefore, sometimes the cell counter gets confused. It is not able to give the color approximately because, there are a lot of cells which are overlapping. But you must realize that a cell counter analyzes a cell 360 degrees centigrade. When we look under the microscope, we are not looking at 360 degrees centigrade. We are only looking at 180, maybe 90. So you must realize that a cell counter is able to detect everything that the sample contains. And that's why it is also able to give suspect flag like an abnormal cell or a blast, because it comes in an abnormal algorithm. But you must realize that a many systemic disease process brings about changes in white cells, also red cells and platelets, which is within the gating area. And therefore, they will never be flagged. But fortunately, these changes are also reflected in the output of the cell counter, though it is not flagged. So therefore, people are trying to develop newer parameters based on these particular changes which are reflected but not flagged. Fortunately, some of the cell counters will also give you objective data. So it will tell you what is an average size of a neutrophil in a human being, average size of a lymphocyte in a human being, average scatter of a neutrophil in a human being, average conductivity of a neutrophil in a human being, average scatter of a lymphocyte in a human being, and also average fluorescence of a lymphocyte in a human being, average fluorescence of a neutrophil in a human being. And therefore, we look at developing reference ranges for these parameters because cell counter are providing those cell population data, which are called as positional parameters or information on the cell, whether the cells are normal or they are abnormal. So what we did was we actually did reference ranges for some of these cell counters. We chose 3,000 healthy blood donors who come to our blood bank, and we looked at our data on the average size of the neutrophil, average scatter of the neutrophil and lymphocyte monocyte. And we compared this data with other centers in the world, including 2 in India, 1 in Bombay and 1 in Delhi, 1 in Miami, 1 in Switzerland. And we found that the white cell data across the population is not different, reference range wise, in the population. Similarly, some cell counters will also do reticulocyte count based on the extra staining of the reticulum, the red cell. Therefore, it separates the reticulocytes from the red cells. And therefore, it also gives you the cell population data of the reticulocyte, basically the size of the reticulocyte, the conductivity of the reticulocyte. Simultaneously, it will also give you the size of the red cell, the size of the, which of course MCV is there. But here, we are talking about a different so it will give you a lot of information on the red cells. Now coming to the most common hematological condition in the world, iron deficiency anemia. So I'm sure you may have seen at least in your among your slides, at least 70% of the slides have been anisocytosis with microcytosis and hypochromia, isn't it? So you must realize that that is what we are being taught. Now, if you look at slides, I mean, these two pictures, what is more obvious? Is it size or is it color? Is it hypochromia more obvious, or is it the size of the red cell which is more obvious? It's a hypochromia. And more than that, you must realize that there is something which is very important in iron deficiency anemia. That is anisochromia, the difference in the color of the red cell. Anisocytosis is fine. Anisocytosis is not easy to identify because very subjective. You know, one day if you show me a slide, I'll call the red cell microcytic. The next day, same slide, I may call it normocytic. It's very subjective. But when I look at the color will tell me whether there is hypochromia, and if there is hypochromia, is there anisochromia? Yes, anisochromia are far easy to identify. So if you look at the top slide, you can see the anisochromia among all the red cells. This is a classical picture of iron deficient erythropoiesis. I'm not talking about iron deficiency anemia, but iron deficient erythropoiesis, whenever it happens, whether it happens in a patient with thalassemia, you can see anisochromia. If you don't see anisochromia but hypochromia, it is thalassemia. But to identify a person with thalassemia who has got iron deficiency, the best picture is to identify anisochromia. And that's not, you know, many times you always, when you report HPLC and you say that, okay, I have got a thalassemia carrier, but, you know, I'm not sure whether it's iron deficient or not. Look at the blood picture. If there is anisochromia, there is no thal major alone. There is iron deficient erythropoiesis also happening. It's an absolute proof of iron deficient erythropoiesis. So just to show the application of anisochromia in nephrology practice, a 72-year-old gentleman, CRF on hemodialysis, history of ischemic heart disease, his hemoglobin drops to 6.5. And, you know, he shoots up, you know, I don't know whether any of you have a, you know, because most of our work in the lab, but, you know, whenever you work on the clinical side, I'm sure you remember what is called orthopnea. When the hemoglobin drops so low, and person with an ischemic heart disease, or is a person who develops ischemic heart disease, they sit up in bed with shortness of breath because the hemoglobin is not enough to supply to the body. So this guy shoots up in bed with a hemoglobin of 6.5. He's taken to the hospital. His ferritin is 521. So they say, okay, fine. You know, why is his hemoglobin so low? His ferritin is all right. So they plan for a bone marrow. He panics. He thinks bone marrow is one of the most dangerous procedures in the world. So he contacts us. We said, don't worry, take a peripheral smear and send your peripheral smear. So one of the most important things is when you look at a peripheral smear in a patient with chronic renal failure or anemia of patient with chronic renal failure, the first thing you want to know whether the patient is producing adequate erythropoietin, because erythropoietin is important for reticulocyte production. So first thing that we look at the smear is the reticulocyte. So you can see that the smear we look for polychromatophilic red cells. So in this smear, I can see 1, 2, 3. I can see 3, and I can see even 4 reticulocytes. 4 reticulocytes. So that means I know that this person is having adequate erythropoietin. So there's, but what I see here is, and I'm seeing anisochromia. I'm seeing red cells which are hypochromic, variably hypochromic, and some red cells which are normochromic. Now the issue is, I want to identify whether this patient has got anemia, whether the hypochromic red cells are a new story. That means it happened recently, because you must realize that lifespan of a red cell is 90 to 120 days. So whether these hypochromic red cells have been there for 120, and whether the normochromic red cells have happened recently, basically means, okay, fine, this guy is recovering from it. But if suppose the hypochromic red cells have happened recently, that means we are looking at a bad story. So how do I say whether the hypochromic red cells are recent or 120 days back? Very simple. To look at the color of the reticulocyte. Because reticulocyte's lifespan is only 2 days, not 120 days. So you can see that one reticulocyte is normochromic and one reticulocyte is hypochromic. That means this philosophy of anisochromia, that is hypochromic red cells and normochromic red cells, is happening on a daily basis, which is the philosophy of anemia of chronic disease. That is the iron that has to be deposited in an erythroid is blocked by inflammatory marker. That's why you get anemia of chronic disease. So my report to the nephrologist is that erythropoietin is adequate, but iron incorporation into erythroids are deficient in uniformity. So what's the treatment for this patient? You have to give him iron. You need to pump him with more iron, even if his ferritin is 521. Of course, because he had orthopnea, he had ischemic heart disease, he was given blood transfusion, but in 2 weeks, his hemoglobin was 11.2. So if you see a patient with anemia of chronic disease, look at reticulocyte count first, then look at anisochromia, and then decide whether you want to give the patient only iron or you want to give erythropoietin. For example, in the next case, you can see there is hypochromia in some of the red cells, but there's hardly any reticulocytes. So this person should not only get iron, he should also get erythropoietin. And if he's already on erythropoietin, he should be given an additional dose or an increased dose of erythropoietin. Because, erythropoietin doses are titrated based on the hemoglobin. So yes, you can give a lot of information to the nephrologist telling that, man, you have got, iron deficient erythropoiesis, you have to give iron, but looks like your patient also is not having adequate erythropoietin. So the nephrologist said, no, I'm already, the patient is on erythropoietin. Okay, maybe you have to increase the dose. It makes a huge, he makes huge impact on the nephrologist, because nephrologist will listen to you and increase the dose of erythropoietin, and when the hemoglobin goes up, he will respect you for the rest of your life. Okay, so now coming back to my cell counter. I was never taught anisochromia by any of my teachers. In fact, for the first time, if you have not been taught, or your teachers have not been attending CMEs where I have spoken, you will be hearing anisochromia for the first time. And I understood anisochromia when I realized there was a cell counter which gives a measure of anisochromia, because it will give you what is known as hemoglobin distribution width. That's from ADVIA. It will give you percentage hypo. Only issue is whether the percentage hypopenic red cells are 5 or 120 days back. But the same cell counter which can give you HTW and percentage hypo also gives you a parameter which is called as CHR. That is reticulocyte hemoglobin content. Hemoglobin content of reticulocyte is probably the earliest indicator of iron deficiency among the parameters that are commonly available compared to zinc protoporphyrin, which is not easily available most of the world. So hemoglobin content of the reticulocyte is probably the earliest indicator of iron deficient erythropoiesis. So I realized that I learned a lot about iron deficiency anemia or anemia from cell counters, because of this concept called hemoglobin reticle of the reticulocyte. Some of them are calculated, like RET-HE and RHE in Sysmex and Mindray. Some of them are measured, like in ADVIA and Alinity, is using the my algorithm. So I always tell people that, sometimes cell counters can teach you morphology, provided you understand that it is actually doing morphology, but giving you some other data. It's for you to convert what you have in your mind as morphology of the red cells or white cells and what the cell counter gives. If you connect that, then you can easily say that cell counters are actually doing morphology, because percentage hypo and HTW, which I learned first time from the cell counter, is the best diagnosis for iron deficient erythropoiesis. THR or RHE is the earliest indicator of iron deficient erythropoiesis. And when the patient starts treatment, and if they are compliant to treatment, that's the most important. Starting treatment is different. Compliant to treatment. So I have got a lot of patients, we call it pants down. I've got a lot of patients pants down when they say that they actually are in treatment, but I know that they're not taking treatment, because when you start treatment, you can see the shift in HCW. And this was all taught by a cell counter. So yes, cell counters are very good morphologists as long as you're able to understand what they're trying to tell you. So there's a scenario here. One of my colleagues who actually was had malignancy, was on chemo. She was iron deficient. Her hemoglobin drops to 5.4. Of course, there is iron deficiency also. There's low MCV. So the husband calls me and says, I'm coming to hospital. I've asked for 2 units of blood transfusion because she is very weak. I said, no problem. So I had access to her hospital number. So I looked at her cell counts and I looked at her smear. I found there are hypochromic red cells with definite anisochromia, but few of the red cells were very well hemoglobinized. So immediately I looked at the reticulocyte and I found that reticulocytes were also well hemoglobinized. All the reticulocytes. There was no anisochromia in the reticulocyte. All the reticulocytes were well hemoglobinized. That means all the reticulocytes that are coming out, which is also on the higher side, because she has got reticulocytosis, is that these reticulocytes are going to have fantastic hemoglobin. So I called the husband and say, it's responding well to iron. Now, the issue is when I look at the smear and I say that the reticulocytes are well hemoglobinized, the reference range for the RET-HE or CHR is 33 to 35. So I'm not sure whether it's 33 or 35. If it's 35, then news is better. If it's 33, okay, still good. But 35, if I could confidently say that it's 35, then obviously the story is different. But I can't say 35 just looking at the morphology. So I looked at the cell counter and I found that the RET-HE was 42. And 42 was not possible by morphology, even if it is a calculated parameter. So I called the guy and said, do you really want the 2 blood transfusion? The next hemoglobin, the next red cells which are coming out fantastically. If she's not that unwell, if she can take bed rest over 2 days, anyway, 2 days later, we are doing a hemoglobin. If you think that she can tolerate the sickness, can we avoid the transfusion? Because, transfusions are always harmful. We don't know when a wrong thing can happen. So, anyway, 2 days later, her hemoglobin was checked. Her hemoglobin was 8.5 without any blood transfusion. Now, in certain cell counters, reticulocyte counts are done by manipulating or processing the red cell. So here we have a cell counter which actually stains the reticulocytes by mu methylene blue, which is the gold standard. And then they smear the red cells and then remove the hemoglobin. So now if the red cell passes, it creates some scatter. But when the red cell goes along with the reticulocyte, the scatter will be more and will produce the reticulocyte separately. So you must realize that this particular cell counter is not only staining the reticulocyte, it's also swelling the red cells and removing the. So there is an isotonic swelling of red cells. So in conditions called hereditary spherocytosis, we know that MCHC is very common. MCHC is quite high, but the problem is with latent iron deficiency in India, you will never get an hereditary spherocytosis where the hemoglobin is more than, the MCHC is more than 36. So we looked at this particular process of this sphering of red cells, and we found that when the red cells are sphered, they become slightly higher than the MCV, which is measured by the impedance data, because they are sphered and they become more voluminous. But the process of sphering was realized that the red cells are also getting ruptured in patients who cannot accommodate the extra volume. So in hereditary spherocytosis, because there is hardly any volume of ratio to the surface, moment you start sphering the red cell will start breaking up. It's like osmotic fragility. So it's like almost like an in vitro osmotic fragility. The MSCV will be always lower than the MCV. So one study we did, we found that the MSCV is lower than the MCV, but more interestingly, we found that the MRV was lower than the MCV in patients with hereditary spherocytosis. This is a previous data, but the new data shows that the MRV is lower than MCV in patients with hereditary spherocytosis. Coming to fragmented red cells, you can see the red cell histograms will reflect fragmented red cells. You can see that, and this is very dangerous. And if you don't look at the histogram, you must realize that red cells are in millions. And this particular area of the fragmented red cells is overlapping into the platelet area. Red cells in millions are getting counted as platelets. So thrombocytopenia, which we actually may think that the patient may be having a platelet count of 50,000, may actually be a platelet count of 10,000 because the red cells are being counted as platelets. So there are some cell counters which give you data called fragmented red cells, but please be careful about this data. So whenever you look at fragmented red cell proportion that is given by the cell counter, which is fairly accurate in cell counters, which are counting fragmented red cells or schistocytes. But if the MCV is lower than 75, that data is not reliable. If the MCV is more than 80, then the percentage fragmented red cells is very, very reliable. And in fact, you can even report that for the nephrologist or anybody who is managing patients with thrombotic microangiopathy. It's a nice article that came from that. So utility in thrombotic microangiopathy, mild hypochromic and microcytic red cells results in overestimation of FRC. 2-TMA shows high sensitivity and specificity at a cutoff of 0.5%. Overall high sensitivity and poor specificity has been reported. So automated fragmented red cells has got a very high negative predictive value. So fragmented red cell estimation by automated methods tends to be progressively different from measurements by microscopy when schistocyte counts increases. Fragmented red cells can be a useful tool to monitor patients with TMA for clinical response. The role of peripheral blood examination remains a gold standard for accurate schistocyte examination. Only thing is, when you look for schistocytes, you should realize that some of the schistocytes change shape over a period of time. They can become microspherocytes also. So automated counting of FRC is merely a screening method and is complementary to microscopy. So therefore, if you are wanting FRC, no, you can't go by FRC alone. You have to do a manual counting. But you can see this fragmented red cells on your red cell histogram also. So you can get fragmented red cells as schistocytes, which are fragmented red cells or tiered up red cells, like you can see TMA, B12 folate deficiency, cardiac valve hemolysis, or you can see them in keratocytes, which are bitten cells, which are because of oxidant hemolysis, like G6PD deficiency, oxidant hemolysis, unstable hemoglobin, and hemoglobinopathies. So coming to another case, close to a death scenario, 17-year-old male student of IIT Madras. He gets fever. His father is the head of ICU. He gets preventive admission in ICU because he's tested positive for dengue, and therefore the father thinks that he may develop a dengue hemorrhagic fever. But every day his platelet counts are dropping. So I saw him first when his platelet count was 75,000, and it's been dropping, become 4,000. The father said, should we give him platelets? I didn't want this guy to get harmed because he's a staff kid. So I said, then risk of CNS bleed is only when the platelet count is less than 1,000. And I knew that no cell counter will give a platelet count of less than 1,000 till one idiotic cell counter gave me a platelet count of 1,000. Now this is you can see the platelet count is 1,000. So now the father is calling me and said, okay, platelet count is 1,000. Should we transfuse platelets? So I said, give me some time. Let me look at the peripheral smear. So he said, how long do you want? I said, I'll get back to you in about 2 to 4 hours. So the issue is, our cell count is reliable when there is thrombocytopenia. You must realize that when cell counters, the impedance-based platelet count basically looks at the events in the red cell chamber, but any events less than 30 to 25 femtoliters are considered platelets. And you can see that it creates a histogram based on the data collected from the cell counter. And to accommodate for those large, unphysiologically large platelets, which is part of normal platelet physiology, normal platelet anisocytosis, it fits another curve. And the area under the curve is the platelet count. So platelet count is not directly measured. The area under the curve is the platelet count, and similarly other parameters are. So here you can see that platelet count is 21,000. Look at the distribution. Most of the platelet counts are between 2 and 10 femtoliters. Hardly any platelets between 10 to 20 femtoliters. So you can see here, most of the events are between 10 and less than 10. So even if I here, of course, you can see that there are few events that are happening. Events between 10 and 20 are increased, and there are more events happening after 20. This is because of a few large platelets in the smear. So this platelet count was not 79,000, but slightly higher than 79,000. But when you get a histogram where the events are actually peaking between 10 and 20 femtoliters, you can see that this is because of the giant platelets or large platelets. The platelet count was, by the cell count was 68,000, but looking at the histogram, I looked at the smear and the platelet count was 250,000. Now, when you see a histogram like this, where the events are increasing between 10 and 20, but they're peaking at 20, that basically means the red cells are contaminating, the small red cells are contaminating the platelets. For example, you can see here, there are small red cells, which can either be an iron deficiency or something else that can be counted as platelets. This platelet count is actually 20,000, not 99,000. So look at the histogram. So I have been looking boys peripheral smear. On the day it was 75,000 here, But you can see that, as his platelet count start dropping, his platelet, which is normal morphology of normal size, they start becoming larger. And you can see that this is when the platelet count was 20,000. This is when the platelet count was 10,000. You can see that most of the platelets are large and bluish in color, which we call as large young platelets. So what are large platelets? Large platelets are defined as anything which is beyond physiological and isocytose. But giant platelets are defined as those which are larger than red cells, as you can see in this two pictures. The interesting thing is when you look at the platelet histogram, it will reflect the large platelets. So you can see, the patient, as the number of large platelets keeps on increasing, you can see the histogram reflecting the large platelets. Only thing is when the giant platelets, it gets confused and abruptly stops. So issue is, can MPV reflect large and giant platelets? Okay. When the large platelet proportions are increasing, you can see the MPV goes up. But when there are giant platelets, it gets confused and completely. So MPV is not a reliable parameter for platelet morphology. So is there another role called optical platelet count? You know that optical platelet count can be done by two methods: by light scatter, which is done by the advent light ality, or it can be done by fluorescence, which is done by Mindray and Sysmex, which is called as platelet or platelet F. So when we got this machine, we said, okay, let's evaluate this machine. So we looked at scenarios where we had normal distribution of platelets, scenarios where we had large platelets. We get a lot of patients from eastern part of India who have large platelets, and we found that whenever the platelets were large, you can see that macrothrombocytopenia, the optical platelet count was much higher than the impedant platelet count. So you can see that there, but when the platelet count or platelet distribution was normal, we found that impedance was higher than the fluorescent platelet count. That means fluorescent platelet count was either missing or impedance was overestimating. But then we found out that fluorescent platelet count is missing out on small events because of background noise. So that means smaller platelets will be missed by the fluorescent platelet count. If you have a platelet distribution like this, you can see that, there are few small platelets, there are regular platelets, there are large platelets. The impedance platelet count was 40,000 and fluorescent platelet count was 46,000. But if you look at the smear, the platelet count is almost 90,000. So the place where the platelets overlap, the one platelet per oil immersion field is equal to 15,000. Where the red cells overlap. So that's very important. So that's where you count the platelets. So the reason why the impedance and fluorescent underestimate the platelet count is because the impedance miss the large platelets and the fluorescent miss the small platelets. So whenever we have a thrombocytopenia, all the lab technicians and doctors are asked to look at the histogram. If the histogram shows normal histogram, normal distribution, don't look at the smear, release the platelet count. If the platelet count, if the histogram reflects that there are going to be giant and large platelets, do an optical platelet count and release it. But if you see platelet anisocytosis on the histogram, make a smear and correlate with it. So when you look at this scenario here, there's another parameter that comes up, which is called the IPF, immature platelet fraction. I don't like using that word fraction, but there's a word that IPF comes up here. And we found that in patients with thrombocytopenia, IPF can predict recovery based on certain papers. There's one paper that came from India, from Hinduja Hospital, which said that this in IPF can predict platelet recovery in patients with dengue 48 to 72 hours from the time it goes up. 48 to 72 hours. I've got a father sitting on my head who's telling that I want the platelet come in, whether the patient should get a platelet transfusion or not. But we also realize that IPF is based on scale, our platform, which compares fluorescence with the platelet size. The FSC is the platelet size and fluorescence. And there's a or almost 100% correlation between the size and the larger the platelet, more fluorescence it will have. Smaller the platelets, less fluorescence it will have. So let's look at this boy. When the platelet count is 10,000, you can see that this platelet, one platelet is large and one platelet is not that large, but both are large young platelets. They are young. They have been produced probably in less than 1 day. They, if you want to call them immature, you can call them immature, but they are very, very young. But the large platelet will be called as IPF and the small platelet will not be called as IPF. So therefore, immature platelet fraction is a very wrong statement. And then later on articles very clearly said that immature platelet fraction does not recover, predict platelet recovery. We realize one thing is that when the platelets are large, that is in eastern population of India, May Hagelin anomaly, Bernard Soulier, you can have IPF which is more than 90%. 90%. Even the people who manufacture cell counters have never seen an IPF more than 90%. And the interesting thing is, in the WNR channel where there's fluorescence, some of the platelet, which is actually the default white cell count, some of the platelets may get counted as white cells and will exaggerate the white cell count. So IPF, a misnomer. In fact, there's a beautiful article written by Pablo, what is it? Mario Plebani, who writes, everybody quotes him for all the pre-analytical errors. Mario Plebani very clearly wrote that, IPF is a injustice given to large young platelets because large young platelets are functionally more active than normal platelets. So it's unfair or not illegal, unethical to call large young platelets as immature platelets because immature platelets we assume that are not going to function normally. So if you want to call something immature platelets, you can call poor platelets because they're not going to be functionally as effective as platelets. So IPF is absolutely a misnomer. It's not even worth considering. And if your clinicians, if your physicians, pediatricians, obstetricians asking for IPF, please make them understand that it's a fraud parameter. At the same time, when you look at the histogram, you can see the large platelet on the histogram. And it correlates very well with and studies that were carried out found out that there's a good correlation with large platelets versus the IPF. So I have been looking at this boy's peripheral smear, and then I see this particular peripheral smear, and I see these platelets. These are called as stress platelets. My professor used to call them as stress platelets. You can see that they are not larger than red cells, but they are bluish, intensely blue in color. They almost look like lymphocytes. These platelets are produced when the platelet count is imminent. The recovery is imminent. So I called the father and said, I'm seeing stress platelets in this your son's picture. So he said, what does it mean? I said, platelet recovery is imminent. So how soon? I said, so I somehow said 6 hours. So he said that we'll collect the blood sample after 6 hours. I said, why do you want to get unnecessarily poked? Anyway, tomorrow morning we'll collect the blood sample. It's all right. If as long as there is no untoward events, don't collect the blood sample. So yes, he agreed. So I could not sleep that night. I just could not sleep that night. So at 2 o'clock in the morning, I asked the technician to go and collect the blood sample and do the platelet count. The platelet count was 25,000. But such arrogance, it's not arrogance. It's basically you must realize that whenever hematology happens, it happens in context of something else. So you can see that I was actually looking at his cell counter data, and I found that he has got some abnormal lymphocytes, which they're not lymphocytes, they're monocytes which are infected with the virus because dengue virus is monocytotropic. If you look at compared to a normal person, you can see that he has got an additional population of cells which are mononuclear cells, which are very intensely stained according to the fluorescence based on the y-axis. Because of virusites, but it could also be because of the dengue virus, which are tropic to the cell and they're proliferating inside the cell. You can see these cells in many populations, but in dengue, you will find a particular population which is slightly not in continuation with the lymphocyte, slightly separate. It's on the line with the monocyte. That's why their dengue virus are monocytotropic. But this pattern is like an hour of hourglass appearance and very specific for dengue. But they also give an additional parameter, which is called high fluorescent lymphocyte count. And we found that in patients with dengue, HFLC is on the higher side. And you can see that as the infection gets worsened, HFLC increases. As it dampens down, the HFLC decreases. The best part is that the HFLC is a mirror reflection of the platelet count. So looking at 2 consecutive days of HFLC, I don't need 48 hours or 72 hours. Within 24 hours, I can tell whether the patient's platelet count is going to recover or not. Yeah. So it's an objective parameter. and it can be identified on scatter from morphology. Now, coming to a 43-year-old male in ICU, I get a call from a consultant to look for toxic neutrophils because this patient actually recovered from a uretroplasty. He had sepsis, and after day 15 of antibiotics, wide spectrum antibiotics, he was getting discharged. But during the rounds, the consultant felt that he was looking toxic. He wanted me to see whether, because he called me and said, the procalcitonin came back as normal, and I want to see whether the patient has got sepsis or not. So he sent the sample. So he asked me to look at the peripheral smear. And of course, I don't look at the peripheral smear because that peripheral smear can be subjective for toxic neutrophils. We know toxic neutrophils are intensely stained neutrophils. It depends on the stain that you use, whether it's Leishman or Wright James or whatever it is. So I looked at his cell count. His white cell count was 4,300. That's another cell counter. 4,000 is a cell count. 3,600, 4,000. Neutrophils, histogram shows mostly neutrophils. But when I compare it with a normal person's scatter plot, there's hardly any difference between the neutrophils of this person and the normal person. So obviously, when you talk about toxic neutrophils, we are looking at increased granulation. So they thought that, oh my God, all the cell counters can measure scatter very well. Maybe the scatter of toxic neutrophils, which are seen in acute bacterial infection, may be increased. So they looked at a study, and the outcome of the study was very consistent. That is, the size of the neutrophil was always large in patients with acute bacterial infection. And they thought that the scatter may be increased, but actually they found that the scatter was on the lower side. They couldn't explain it, but it was a very good discovery, the fact that sepsis can be identified by neutrophil changes because of large neutrophils and lower scatter. Now, obviously, to understand large neutrophil, if you have to understand hematopoiesis, you can see that a neutrophil from a myeloblast undergoes 4 changes. The myeloblast become half the size. The blue color of the myeloblast disappears. It becomes gray in color. The granules start appearing in the promyelocyte, myelocyte stage. But by the time it becomes metamyelocyte band form, the granules mature. That means they lose the sialic acid on the surface and they stop taking up the azurophilic dye. So it's purely a staining mechanism. And of course, the nucleus becomes band form. So when there is an infection, this maturation, which takes 5 to 7 days, will happen in less than 1 day. And what happens is only the nucleus becomes segmented. The blue color of the cytoplasm does not completely disappear and will appear as Dolly bodies. The granules do not lose their staining property and they appear as toxic granules. That means there's no increase in granules, the same granules, but they have retained their staining property. And the size of the neutrophil does not become less. So toxic granules indicates, Dolly bodies indicates, and large neutrophil indicates that these are neutrophils which have matured in less than 1 day, which can only happen in acute bacterial. So you can see here, the size of the neutrophil compared to normal. Here is a patient. You can see the size of the neutrophils are increased and the light loss or the scatter is decreased. So here I saw that the patient's neutrophil size was much higher compared to normal. So I told called the consultant. I told him that the patient has got acute bacterial infection, sepsis. So he said, but procal was normal. I said, okay, doesn't matter. We have identified sepsis. Why don't you do, anyway, you have to start a blood culture. You have to start an antibiotic simultaneously. The sample that you draw during that particular process, you send it for procalcitonin. And, the procalcitonin in the second sample was 230. Very high. So you must realize that, there's an article that came from NEJM which said that sequential measurement of procalcitonin is a better indicator of sepsis than a single measurement of procalcitonin. So many times, many of these things we have been doing for ages. Some of them remain as anecdotes. Some of them get converted to studies. Not all of them get published, but some of the studies that we have published, there was one sepsis studies where we found that not only the monocyte neutrophil volume, even the monocyte volume is significant in patients with sepsis. And in patients with neonates where we only looked at neutrophils, we found that large neutrophil volume and low neutrophil scatter was a fantastic marker for sepsis. And when we combine it with other markers of sepsis like leukopenia and thrombocytopenia, the specificity of diagnosis of sepsis was almost 100%. And the sensitivity was 90.8. You can't get better than that. Now, if we look at other cell counters like XN, we know that there are something called here. This is the same patient, the same patient. We are not talking about anybody else. Same patient. Here, if you look at a normal distribution, this patient is slightly reactive. You can see the reactive lymphocyte left shift. But if you look at the neutrophil data, you can see that neutrophil data along the x-axis, along the y-axis has got more fluorescence compared to normal neutrophil data. And that's because of the RNA, the nucleic acid stain, which is a fluorescent dye that stains the nucleic acid, which is Dolly bodies. And we found that in sepsis with patients with high fluorescence, the sepsis diagnosis is much higher than non-sepsis patient with almost an area under the curve of almost 0.9. So that's a nice cell counter which can pick up sepsis even if it does not measure size. And the best part of it is that, many years back there was an article which said that eosinopenia can be the earliest marker of sepsis in 1965. But we should realize that whenever we do eosinopenia, we should use our own reference range, not the reference range which is published in DACY or anything like that. That's 40 to 440 per cubic millimeter. It is actually 200 to 600. When we use this reference range, the differentiation of sepsis in eosinopenia itself was almost better. I mean, much better than procalcitonin at 0.739 area under the curve. So yes, so a lot of studies are being carried on every cell counter to identify that sepsis can be identified not by any one cell counter, but all cell counters. So a lot of people are looking at seeing how we can develop a particular parameter which is very good at picking sepsis, because sepsis has got high mortality and morbidity. So are we looking at an ideal test which is very sensitive, very specific, at the same time not very costly? So there was a study that was carried out in Erasmus in Netherlands, and they came out with this particular data, which actually we came out many times years back, that not only neutrophils, even the monocyte volumes can also be affected in patients with sepsis. And they came out with a particular entity called as monocyte distribution with MDW. They found that the negative predictive value when they combine MDW with WBC was 98%. But interestingly, we found that in a patient who has sepsis, the neutrophils become large. They have the same granules. So in the large neutrophil, the same granules will scatter less, and they will become monocytes. So in a patient with sepsis, if there is no the monocyte is not true, then it is basically the MDW. So here you can see that the neutrophils are large, have the same granules, and because they are large and they have the same granules, they'll scatter less light. So many of the neutrophils will get counted as monocytes, and that increases the monocyte distribution because it overlaps with the neutrophil nucleus. So MDW is nothing but pseudo monocytosis. But when you have true monocytosis, you can see that the histogram will reflect the true monocytosis. This is true monocytosis, while this is pseudo monocytosis. This is pseudo monocytosis. Their monocytes are increased, but this is pseudo monocytosis. So yes, pseudo monocytosis is a very good marker of sepsis in some cell counters. Now here you can see that some neutrophils are mistakenly being counted as eosinophils because they have got more scatter. And the reason for the more scatter is because they have got vacuolization as well as blue-green inclusion. When you have blue-green inclusion, especially in the background of liver failure, this patient has not survived more than 24 hours from the time this is discovered. So yes, these are called death cells. Now coming to a 35-year-old male with fever, you can see the white cell count is 11,000, 10,500, mostly lymphocytes. But you can see the lymphocytes are smaller than usual. We ran it on another cell counter. You can see that, okay, lymphocytes are large. It's 11,000 is a count. But there's another population of lymphocytes below the lymphocytes. And the monocytes are also widely distributed. And there is some population outside the lymphocyte. When 4 of these happen together, the population outside lymphocyte, the lymphocyte distribution is increased, the monocyte distribution is increased, and there's a population under the lymphocyte. When 4 of them happen together, the diagnosis is always malaria. And we found that the population is mostly under the lymphocyte, it is vivax, and the population is mostly closer to y-axis, it's falciparum. You can see the same So you can see here this patient, the patient we saw earlier, it was Vivax, and you can see another patient. You can see the lymphocyte distribution, monocyte distribution. There's a population outside the liver, and there's a population here, and this was actually falciparum. Same patients, you can see that the neutrophils are exaggerated because many of the infected red cells don't lyse and they get counted as neutrophils. And you can see that in the other population, these are infected red cells which are counted mistakenly as neutrophils. So pseudoneutrophilia can indicate malaria in some cell counters. And sometimes you can see that extra population of eosinophils can also be identified as. So pseudo-eosinophilia and pseudoneutrophilia can be an early marker of malarial infection. So pseudolymphocytosis in the cell counter was Vivax, and this was a patient with falciparum. So don't blame the cell counter when you have, when basophils are exaggerated, when eosinophils are exaggerated, because they could be an earliest indicator of what pathology the patient is undergoing. 4-year-old male, you can see that this is the data. You can see that it's slightly different from dengue. It's a straight pattern we call as a, like a rocket trail appearance. And we also find that there's 2 other changes that happens. The neutrophil also looks more toxic, more fluorescent, and they also susceptible to lysis. So the forward scatter is low. So in a patient who has scrub typhus, we find that the HFLC is on the higher side, and fluorescence of the neutrophil is high, and the scatter of the forward scatter of the size of the neutrophil will susceptible to lysis in processing. And the interesting thing is, as you start doxycycline, these changes that happen in the cell counter dampens. So scatterborne morphology is very good because it helps in early and reliable diagnosis of acute febrile illness, helps early institution of therapy, allows monitoring of progress and response to therapy. So last case, I will talk about one of the senior most officers of CMC. He comes to CMC, he's working somewhere else, but he comes to undergo surgery because he has got CA colon. He undergoes resection of colon with anastomosis. He spikes fever on day 4. The CRP is high. Obviously, one diagnosis, anastomotic leak. Anastomotic leak basically means re-exploration. Exploration means high morbidity. And if you don't take for re-exploration, mortality is 100%. So anyway, they decided to take for re-exploration. But again, my surgical ICU consultant said, can we look for toxic neutrophils? Let's call Sukesh. So this guy, gentleman has been having a high white cell count for a long time, 30,000. But his neutrophils look very calm. Look at his neutrophils, very calm. But he's got lymphocytes which are reactive. And they are on a straight line. They are not just above the monocyte, they are a straight line. So I think that is okay. There is no neutrophilia, there are no toxic changes, only a few reactive lymphocytes. Just to verify that, I basically run on another cell counter, and I can find that there is an overlap between lymphocytes and monocyte because of the reactive lymphocytes. Neutrophils look very calm. So again, I say there is only reactive lymphocytes and neutrophils are looking calm. There is no question of anastomotic leak. This fever is because of a viral infection. So then the registrar calls, are you sure? The consultant calls, are you sure? The senior consultant says, are you sure? There's another senior consultant who came after retirement, from retirement, to help in the surgery. He said, are you sure? I said, yes, I am sure. Finally, they don't took him for re-exploration. He's discharged after 10 days with no extra problems. So yes, cell counters will give you a lot of pictures. So yeah. So very clearly, the surgeon consult was no bacterial but viral. Patient recovered and discharged on day 11 from SIC. So cell counter is the first screening test with results available within 1 minute of sampling. This screening test with the specifics is no longer a mere screening test, but provides specific diagnosis, which my colleague Joy Maman calls as machine morphology, but I call it as a hemocytomorphometer. Thank you very much. Acknowledge to my teams.
Thank you. Thank you very much, sir. That was an exciting talk, as usual, and very nicely and elaborately, you beautifully showed us all the possible parameters which potentially can give us information regarding how the cells, how the cell counters per se can give us information regarding various disease states. As is obvious, there are no questions in the chat box so far, at least. So obviously, you must have done a great job, sir. But overall, when we look at cell counters, there are generally, I'm trying to ask a question primarily for the sake of the people, who may not have kind of looked at what analyzers they would like to have in their laboratories. They usually, people get confused because there are just too many choices right now in terms of analyzers to have, and not everybody is as lucky as Professor Nair to have, all the possible analyzers in that center. So if one has to choose, say one particular analyzer, one single analyzer, what should they opt for?
You're asking me?
Yes, sir.
I love all my cell counters.
No, I'm not trying to say that you tell us one brand, but for example, there are a lot of things nowadays, as you rightly pointed out. IPF per se has something which a lot of people push you and ask you to get IPF as a parameter. Now, obviously, that's something which will come only from a fluorescent analyzer.
Yeah.
Then you would also like to have cells at near native state, and when you like to have cells at near native state, then obviously you don't want to get into a fluorescence analyzer.
No.
So, it's like
Yeah.
when you look at all these things coming together, what should you ideally do, in a situation like this?
So, Anil, the answer to your question is, it's not easy. It is, every, like, for example, I have got a community health center here, which is far away from my hospital. I know the type of patients who come there. So when they ask me for a cell counter, I know what is the prevalence of the disease that they have, and I would prefer a particular cell counter. And thing is, I am a big fan of three-part cell counters. I'm a huge fan of three-part cell counters. In fact, I say that three-part cell counters can give far more information than a five-part cell counter. But you can't, when somebody's decided, okay, I want to go a little step ahead. So, like for example, there's a prevalence of, they have their dengue outbreaks, they have their rickettsial infection outbreak, they have a malarial outbreak. I know what's the cell counter I can recommend. So therefore, it is, if somebody calls me and asks me what, so first thing I ask them two things. One is, do you get maintenance for those cell counters in your region? That's first thing. Second thing is the pricing. But most importantly than both of them is that what is the prevalence of disease in their place? Because I give these talks in many other parts of the world, like Muscat and in Saudi Arabia. I know that there's no dengue there, there's no rickettsial infection there. So you don't need to talk about those conditions there. But sepsis happens anywhere else in the world. But you can also see what is the disease prevalence of their region. So my entire recommendation is based on the disease prevalence that is there in that particular region.
I think that's a fair, kind of recommendation with respect to what an analyzer, what kind of an analyzer one should have, depending upon the kind of disease states that you are primarily dealing with. Now I see a few questions coming up in the chat box, and I'll just read out the questions if I'm allowed to do so.
For sure.
So the first question is the location of cells in 5-part histogram same as in 3-part cell counter as far as the WBC histogram is concerned?
No, not at all. Not at all. In fact, WBC histogram is only based on nuclear characteristic, because there is no cytoplasmic features that come up in the 3-part cell counter, only the nuclear characteristic. So it's definitely not the same. Definitely not the same.
And the other question is, what is the reason for variation in mean corpuscular volume in different instruments? What can we do to establish normal MCV range in such cases?
So, yes, it's an important question, because you must realize that many of the labs, see, I work in a lab where I do the analysis of the sample within 4 hours of sample selection. So many labs are not able to do that. So you must realize that many of the cell counters will actually process the red cell, and during the processing of an older red cell, the changes will be far more impactful on the red cell. So there can be changes. I mean, there can be impact it will impact on the outcome of the MCV. So it entirely depends on what processing is happening on the particular cell counter. But most of the impedance cell counters will not have much variation between them as long as it's only impedance. But if there is any other processing that happens, there can be changes in MCV. Yes, MCV is a very important parameter, and any MCV where you are looking at a result which is more than 8 hours after the sample collection, you need to take it with a little bit of, you have to keep the background of the sample collection time when you are interpreting the results.
So if we would say, generally speaking, whenever you will take samples, for example, if we take samples together and we put them across through the analyzers at the same time, all at the same time, maybe within first 2 hours of the collection, we shouldn't find a significant variation
Not
in
at
the
all.
corpuscular.
Not at all. Not at all.
Absolutely. Yeah, I think that's where the questions are. The other question is, sir, dear sir, we are supposed to do manual differential count when we come across pseudo monocytosis. Yeah, should we do I think probably the person is trying to ask, should we do a manual differential count when we come across pseudo monocytosis?
Yeah. So thing is, the moment you identify pseudomonocytosis, that itself is a great thing. So, but some people are cursing the monocytosis part of it because, in a normal person, the monocyte reference range is slightly under exaggerated in the reference ranges. Like I told you, eosinophils reference range in our country is not 44 to 440. It is 0.2 to 0.6. Similarly, the reference range for monocytes are not going to be the same as there in the external reference ranges, because there is a significant prevalence of tuberculosis in our population. So so 10%, anything more than less than 10% is accepted as normal monocyte count.
And would it be right if I say that when you look at monocyte counts across different analyzers, you may not get exactly similar counts, and there might be some degree of variability between them? Would that be a good statement to say?
Yes, I think I think this monocyte has been a big issue which has been there in our country for so many years. So some of the manufacturers may actually build in a factor to underestimate the monocyte count, so that people are very comfortable. But comfort is not important for the pathologist, but comfort is more important for the patient. So please don't deprive the patient of the right care.
Yeah, there's another question which says, should we use platelet I or platelet O? And I would also add platelet F to it.
Yeah, so thing is, the gold standard or gold mark of platelet count is actually the histogram, which basically is platelet I. So look at the histogram to decide before you decide whether O or F is required. If I can help you, conclude, there is no need for O and F.
Absolutely. And there's also a lot of controversy which keeps happening with regard to manual platelet counting, wherein people talk about counting the platelets on the peripheral smear itself and giving value based on that. And obviously, we know that the factor for these counts in different laboratories is extremely different. Like, for instance, in some cases, you might have a factor of 10,000 to as high a factor as 20,000. And obviously, the variability will be 100%.
Yeah.
So what is your take on this particular type of platelet count?
So, I only look at traceability because there's an article that Robert Carmen had quoted for us and he very clearly said, where the red cells are overlapping, that's the most important part. Where the red cells are overlapping, one platelet is equal to 15,000. So, he's got a condition for giving a factor to the platelets. And the red cells are overlapping, that's where you count the platelets. But, a factor of 15,000 to 10,000 is not a major impact on total platelet count, because, what is a platelet count important for? Mostly for patients who are likely to go in for a procedure. And when we look at the transfusion triggers are not very challenging. So, whether you use 15,000 or 10,000, it's not a major problem. But I always use 15,000 because I was trained by Robert Carmen, and Robert Carmen has got a reference to the point that, okay, you can do that. But, every lab can develop their own, because, you must realize that now digital morphologies come in. Digital morphology may not go into the depth of the smear where the red cells are overlapping. They can do the count anywhere else they want. So as long as you are able to validate whatever you're doing with a particular, surrogate marker like flow cytometry or anything like that, I mean, or standard reference method like phase contrast microscopy, then probably you can validate the factor. But I have always used the factor of 15,000 and I found it very, very useful.
And
One more
okay, I think you
question.
probably, yeah, I think probably sir already answered that, but he says like for manual platelet count factor, any role of area covered by oil immersion. I think you just mentioned it. Nevertheless, if you would like to just mention it again, sir.
Yeah. So
which area under oil immersion?
Yeah, the area where the red cells are just overlap. And thing is very interesting to know that, if you know the hemoglobin of the patient, you will able to get to the point of the red cells overlapping, because as the hemoglobin drops, the amount of depth of the smear that you have to get into from the feather edge is little bit more inside as the hemoglobin drops. So you should get to the place where the red cells are clearly overlapping.
Yeah, I think that's where we end with the questions. There are no further questions here, but that was really wonderful, sir. There's also another. Oh no, suddenly there's another question. I'll just take this as the last one. Different microscope lenses cover different areas. Basically, probably we're talking about the area of vision when you're trying to see the smear. So depending upon the area, for example, if you have a 22 meter versus the 18 meters, not the meters, microscopic lens area. In such cases, would there be a difference? Obviously, the factor would be different. Probably that's what is expected.
So
to
area
be
is
answered.
definitely going to be different, because the numerical aperture and all those things can different. But when we're talking about one platelet per oil immersion field equivalent 15,000, that's not going to get affected by the numerical aperture or the area of the lens. One platelet per oil immersion, because that's going to be a very small area of the smear.
Yeah. So I think with that, we will call it a day. Thank you very much for your enlightening talk as usual. It was really, really engripping. More importantly, all the real life case scenarios which you gave, they were extremely, extremely stimulating. I'm sure most of us would have really enjoyed the cases which had come up, and they actually gave us real life information to understand where analyzer has made a huge difference for the patients. Thank you very much for your time, sir. And I would hand it over to the organizers.
Thank you very much for the wonderful
Thank
talk, sir, as usual. And the scenarios which you have explained us, it was like a nightmare for me. So if they ask the second time, is it there, then I will get panicked. But even after so many questioning, you still stand on your thing, which shows the confidence you have in you, and you're amazing hematologist. And we are blessed to have you hear your talk, sir. Thank you very much. Thank you, sir.
Thank you.
Aarti, you want to say
Thank
something?
you.
Yeah.
Thank you very much, sir. Because I am very little knowledge about the hematology. It's very basic, but it is really fruitful to me also. Because
Thank
I
you,
have
Sukesh.
forgot most of the things in these years. Thank you so much, sir.
Thank you, Sukesh.